Thanks for the invitation to be here. I'm very happy to tell you something about the work we and others have been doing in the field of circulating tumor DNA and liquid biopsies, and show you some of the results we have from early prospective studies all the way to some of the clinical trials that are ongoing in this field, and some of the data we have from our trials in Denmark also. These are my conflict of interest here, so I'm collaborating with the C2I Genomics, Vericide, and Natera also in the past. I'm going to show you some data from them. They have been sponsoring this data that I'm showing. I'm going to say some nice things about different platforms. I don't own any stock options or anything in this. They have solely provided the support for the research. So many of you know this, liquid biopsies, there are multiple different specific tumor analytes in the liquid biopsies that you can use for measuring. Liquid biopsies is not just plasma, it can also be urine, it can be saliva, for instance, and as you can see here, you can measure different analytes. It can be extracellular vesicles, it can be circulating tumor cells, it can be urinary, or it can be cell-free DNA or RNA or different proteins or tumor-educated platelets or other metabolites that we can measure in the blood, for instance. And I'm going to talk mostly about blood here, but also urine. It's important for bladder cancer research. The characteristics of cell-free DNA that is important for what we are doing here, and in order to make some very specific and sensitive biomarker system mutations, indels, copy number variations, genomic rearrangements, methylation, fragment size. Also, there's been a lot of publications in this area highlighting different of these molecules as specific biomarkers. I'm sure that most of you here know this, so this is some basic introduction. So most of the cells in our body, they shed DNA from apoptosis or active secretion of DNA. And if the tissue is inflamed, then there is more secretion. And then the same happens in tumor cells also, where you have secretion or you have apoptosis and release of cell-free DNA that then harbors the different mutations that is specific for the cancer. It's highly fragmented, so down to 150 base pairs, just only protected by the nucleosomes, and that sets some demands to how we actually develop the different assays that we want to use for measuring circulating tumor DNA, also because of this fragmented nature of this. And we can measure it in the urine from renal clearance, and of course in bladder cancer that I'm talking about here, that's a combination of the renal clearance from the blood that we see, and then of course also if the bladder is intact, the DNA that may be shed from the tumors in the bladder. There's a half-life of 2 hours approximately of cell-free DNA in circulation, so that makes it a perfect way of using this as a biomarker for real-time monitoring of the tumor burden after surgery or during treatment, for instance. So where can we use cell-free DNA and circulating tumor DNA? It really has the potential to be used from early screening, diagnosis, to prognostication here before surgery, and then after surgery for detection of residual disease also, and for monitoring relapse and novel clones that are developing. I used to show this, that it's important to realize that there are two different kinds of tests here. There's the tumor agnostic approach, where we don't know anything about the biology of the disease that we want to measure. It's more difficult. We have the different companies working in this field, like Grail or other big companies that try to make a screening test for this, but it's difficult, of course, because some will have p53 mutations that may not be cancer specific. So that's one of the challenges. But in the tumor-informed approach, we know the biology of the disease, so we can make some very specific and sensitive assays individualized to the individual patients, and then use that to track the mutation burden or mutations in these specific patients after surgery or during treatment. So this is, I think, this area here of research. This is where we are closest actually to using this for clinical use, and actually to escalate and de-escalate treatment. So I hope I can convince you by the end here that we are actually, this is not in 5 years, this is actually something that we can probably do very soon to start using this. So I think people tend to believe that what you're doing is something that you and the previous generation created, but this is actually cell-free DNA. It was discovered in 1948, where people discovered that there was cell-free DNA in circulation, and then as you can see here, it's been driven forward by different technological advances over time, and then different trials that has been initiated lately here in 2013 and 17, where we started to see some prospective studies in this field. But it is really, it's not entirely new, but our technologies for detecting it are much better now. This is just, I'm not going to educate you on how to treat the patients with metastatic or non-metastatic bladder cancer, but this is just to show where we actually have an opportunity to do something. So, of course, here in the neoadjuvant setting, it would be interesting to be able to know if patients need chemotherapy. Can we de-escalate or escalate treatment? And in this case here, can we do bladder sparing, for instance, based on the information we have from plasma and urine? And especially in this setting here also, where patients, this is the treatment regimen that approved in Denmark, and clinical high-risk patients that are PD-L1 positive, they receive adjuvant nivolumab, and is it needed if they are ctDNA negative, for instance? So I'm going to show you some data from that. Yeah, you can use this monitoring as shown here. So this is some of the prospective study we did some years ago now in collaboration with Natera. We used their tests to look at these mutations we identified from the patients using exome sequencing of tumor and germline, and then identified these 16-plex assays to monitor the disease during neoadjuvant chemo and after cystectomy also, as you can see here. There's one example here where you can see that the ctDNA in this case were positive here in the beginning, then dropped here during neoadjuvant chemotherapy and down to undetectable levels, also after cystectomy, and then became positive here 245 days prior to detection on a CT scan. Of course, this is a long range, and it's not typical, but overall, I think we see this as a marker where it's an average lead time of 3 months over a CT scan. So it gives us an opportunity to do something earlier for these patients. But it is, in this study, a prognostic marker at baseline here before chemo, before cystectomy also, and especially also the accumulated data we see after cystectomy, as you can see here. It's been shown in other studies also. This is the results from the Abacus trial, where they use neoadjuvant immunotherapy, where they show the same tendency here at baseline, before cystectomy and after cystectomy, and that detection of circulating tumor DNA is really associated with outcome of these patients. We did a study where we now had full clinical outcome for the patients in the first study that I mentioned in the prospective study from our side. And now we saw the same tendency in this, where we now had 5 years of follow-up from the patients. This is again before neoadjuvant chemotherapy, before cystectomy here. We start to see some late events here, and especially here also, if we look at the accumulated data after cystectomy, we see some events here, and of course it makes sense that we start to see this because the evolution of the cancer is ongoing, and the test that we designed 5 years earlier, it may not be able to detect some late recurrences. But I think here, for practical purposes, where we want to escalate or de-escalate treatment in a window maybe of 3 or 4 months after cystectomy, it's not really an issue here. In this study, we also tried to select a cohort we had where a patient didn't receive any neoadjuvant chemotherapy. So it's a retrospective cohort. It's not optimal for doing this, but we still try to use this to see what can we detect in this cohort, to see if we can say something about de-escalation of neoadjuvant chemotherapy. So this is the status of ctDNA before cystectomy and after cystectomy here. So you see we have more events here in the ctDNA negative arm. But if we compare that to the NAC-treated cohort here, you can see that there is a higher frequency of recurrences in the non-treated patients here, but it's actually not significant. it may be significant if we include more patients, but it may also be that the retrospective nature of this cohort means that we have a sensitivity issue about detecting ctDNA. So, of course, you should always be careful about doing these cross-cohort comparisons, but this is when we compare the ctDNA positive patients between the cohorts. We don't see a survival benefit for the chemotherapy treated. So the question is also if this is actually an effective enough treatment for these patients. But we really need to do a randomized clinical trial in this setting to see if we can de-escalate neoadjuvant chemo to patients. I think that would be, of course, if we're talking about bladder sparing approaches, it may be a huge thing for the individual patient. But I think here, if you can de-escalate chemotherapy for larger groups of patients, I think it will have a huge benefit of quality of life and outcome. So, yes.
We'll go back one slide. You're just looking at ctDNA as a prognostic factor, which is in part perhaps related to burden and other aspects of proliferation, cell death, etc. But to ask that question, wouldn't you also have to, in some way, roll in specific genomic alterations because someone knows prognostic? So had design a trial where it would also
I think I would say in this case, if patients are ctDNA negative using a very sensitive test, I think it would maybe safe to avoid giving them chemotherapy or other chemo-immuno combinations here. But of course, if we're talking about bladder preservation trials, then it's something else, I think, with the DNA damage response markers and so on. So
it's interesting that you're suggesting to only treat ctDNA positive patients with chemo, but you're showing here that it looks like there's more benefit for ctDNA negative patients.
Yeah. So, but I think I think the de-escalation is the most important part here. Then we, of course, can discuss if the treatment efficacies are high enough for this. So, okay, so now I've been talking about assays where we use up to 16 markers identified from exome sequencing using the Signatera approach. This is a study published some years ago. That they lay the groundwork for a company called C2I Genomics, where they demonstrate some probability of detecting circulating tumor DNA using a single marker and then moving into whole genome sequencing, where we use tens of thousands of markers to identify if patients are ctDNA positive. So what you can see here is the tumor fraction, how much ctDNA do you have in the plasma? What is the fraction you can detect? This is 1 in 100,000 here, as far as I can see. So you really need to have a high coverage here, and the tumor fraction is not as high if you go into multiple markers theoretically. So here, theoretically, you can detect lower amounts of ctDNA down to 1 in 100,000 here using less coverage. So that means that you can do 20 or 50x whole genome sequencing instead of so that's a clear advantage of this technology. So we collaborated with them in using this approach, where we then used whole genome sequencing, tumor and germline, built the models based on the different mutations, alterations we find in the individual tumors. So and it's important to realize here that we don't need to detect all the mutations, but if we just detect 2% of the mutations we see from the whole genome sequencing, then there's a very high probability that this patient is actually ctDNA positive. We can then detect that using the whole genome sequencing of the plasma samples here, where we then try to, in this very illustrative example here, to try to search for the mutations that we found in the primary tumor. The good thing about this is that this can be applied in a genomic center associated with many large clinic facilities also, where you can then sequence the materials from the patients. There's no bespoke assays or capture of specific mutations. You can upload this sequence data to a server and then get a call if patients are ctDNA positive or negative. So I think that's a huge advantage for this. But again, I don't have any stock options in the C2I Genomics here, but I think it's from from a practical point of view, I think this is a good way, especially if you move outside of North America and want to use these kinds of tests. So we tested this in 2 different labs where we made the libraries from the bottom up, and then tested it in Aarhus and then in a US-based facility also. This is the correlation between the variant allele frequencies and if they are positive or negative. So we see a high correlation in this from these samples that we included in this correlation here. And this is the result from this study where we used 112 patients from this prospective study we have. And again, here you can see this is the cystectomy time point you have here. And above you have patients that develop metastasis later on, and here they don't develop metastasis. And you can see here that many of the patients actually have a ctDNA positive test very early, actually earlier than a diagnosis here before neoadjuvant chemotherapy is initiated. So this actually seems very sensitive also. And again, if we use this after accumulated data after cystectomy, we see similar high performances of positivity and negativity of the ctDNA in correlation to outcome for the patients. This is the lead time of using this. So here we have a 4-month lead time. If it's 3 or 4 months, I don't think we've demonstrated that it's actually better, but if we can actually use it where it's comparable to what we found earlier also. And interestingly here, using from this accumulation here, we can see that patients with later metastasis, they actually have an accumulation of ctDNA very early on, indicating that we can measure ctDNA in a window early after cystectomy and identify these patients. So from that, I'm going to shift gear a little bit and talk about how we can use it for evaluating response to treatment also, and how it's been used in the neoadjuvant setting and in the adjuvant setting also. So we've been studying this here in the first paper here, where we correlate the dynamics of circulating tumor DNA to a pathological complete response. And in some cases, we found a nice correlation between this, where there's no response and there is response here from a clinical evaluation. And then we have some examples where we see some opposite characteristics. And if we compare that to outcome as gold standard here, we can see that the pathological downstaging is actually not in this cohort. I know in larger cohort it's of course associated with recurrence significantly, but ctDNA dynamics is actually more significantly associated with outcome compared to pathological downstaging. And it makes sense, of course, that you have a systemic response evaluation compared to a local response evaluation using pathological downstaging. We use the whole genome sequencing also to do the same from this study. Well, again, we see a correlation between presence of tumor, of course, and the dynamics of ctDNA. And again, if we correlate that to recurrence-free survival, we can see that if patients don't have any ctDNA, they have a very good outcome. And if they continue to have ctDNA during the treatment, have that poor outcome, as I showed you before. So this has been demonstrated in the Nabucco trial also, where patients received the adjuvant immunotherapy also, where ctDNA levels were significantly associated with the pathological downstaging in that trial also. And this is the famous example from Paul Sedal, from the IMvigor 010 trial. That was a negative trial of atezolizumab, but when they then afterwards made a sub-analysis of ctDNA in the study, they could see that patients that were ctDNA positive actually had a survival benefit when they received the immunotherapy, atezolizumab in this case. And that's correlated also with the reduction or clearance of ctDNA is significantly associated with outcome in this cohort. What's interesting to see in this study here is actually that there's a 40% recurrence rate in the patients that are ctDNA negative. So I think discussing this earlier with the quality of the samples, I think that I was discussing this with Tom Pauls at some time, and I think the samples when they did this trial were not collected specifically to run ctDNA tests on. So, but still, and that may give them a sort of a sensitivity issue in this arm here, but still they demonstrate here that they can actually identify patients that may benefit from immunotherapy using a method like this. So what about combinations with urine and plasma? we did a study where we selected the plasma samples we have from the same patients as I showed you earlier, identified up to 50 mutations per patient, and then made our own homebrew NGS panels for this, and looked for these mutations in the urinary DNA that we selected during neoadjuvant chemotherapy. This is the results from before, where we see that the ctDNA status is significantly associated with pathological downstaging and associated with outcome also. If we look at just the ctDNA, urinary tumor DNA, we see the same. We see also that, of course, it's associated with pathological downstaging. Makes sense that if you still have tumor present in the bladder, then you have mutated DNA in the urine. You can also see here that the urinary tumor DNA is associated with the recurrence-free survival after cystectomy. If we combine this, we get this overview here. Now we're down to few patients, so we of course need to do this in larger cohorts. But again, if they are both negative, they have a superior outcome, and if they're both positive, they have a really poor outcome in this case here. Of course, the urine analysis is tricky, because if we see a signal, we know we have the signal. If we don't see the signal, we don't know if it's because of dilution or if it's because of all the handling of the urine sample. So there is some different ongoing initiatives on how to actually how to report how we handle the urinary samples and how we should do this. If we'll ever have as good data from urine as we have from plasma, that's a question. So because of the homeostasis. So, but let's see. But it may be a strong assay to use for if we're talking about doing bladder sparing approaches for patients with bladder cancer. So Roger Lee, he made this commentary in Nature Medicine last year, where he show that there may be different ways of handling this. If patients are both ctDNA negative in plasma and urine, it may actually be a candidate for bladder preservation. And then, of course, we should include some other markers of DNA damage response and other markers that indicate that they have a higher likelihood of responding to treatment. And then if it's only positive in the urine, it may be a patient for radical cystectomy. And if it's positive in both, it may be a patient that should have another kind of treatment. Then moving on to monitor clonal evolution using this. So now we are in the metastatic setting. We started this in our first study here in 2019, where we then, for the patients that were ctDNA positive, using the 16-plex assay. Of course, we cannot detect anything new using that assay, but we can use it for identifying patients where it would be, or samples where it would be interesting to do deep exome whole genome sequencing. So we did this in this case up to, I think it was 500x coverage on the tumor and the plasma samples. And for this patient here, we can actually see now, it's 118 days after surgery. There's no really, we would expect to have new mutations here on this axis here if we see new clonal developments. We don't really see that for that patient. We see this for, in this case here, where we have another patient where we see that patients start to deliver these new mutations that may be harboring or may actually be some new actionable targets that we may be able to use for selecting treatments.
Do you have there if there was adjuvant treatment or stratified?
If I have that for these patients, no. In this cohort, we had very few patients receiving adjuvant treatment. So it was before introduction of immunotherapy, things like this. So this is the study here from this group here. So studying in metastatic urothelial carcinoma and studying the correlation between the primary tumor and what's possible to detect in the cell-free DNA. It's very interesting to see here that the genes, when you compare this to TCGA, it was sort of similar frequencies between TCGA and what's actually present in the plasma samples. Interestingly here also, when they then compare to the tumor variant allele frequency to the plasma variant allele frequency, there is an overall large overlap between what you found here and I think the important thing here is also to realize that there are these new mutations arising here in the plasma that's not detectable in the primary tumors. So, and these may again be something that are important for targeted treatment. This is another study from Clinton et al. In 22 also, where they looked at the overlap between primary tumors and metastasis based on cfDNA also. And overall, there is a nice correlation between this, but they see differences when they look into these different specific genes here over time, from the primary tumor to the metastatic lesions into the cell-free DNA. And importantly, also when they look at these patients receiving erdafitinib treatment based on FGFR3 alterations, they can actually see that this patient, when they're monitoring using cell-free DNA, they can see a whole range of new alterations arising during the treatment of this patient. So it is a little bit scaring, and this is a way of understanding why these targeted treatments are not that effective all the time. We studied the whole genome sequencing here, as I mentioned, and then looked at the mutations that were present in the primary tumor and plasma, and what is shared also. So the third column here per patient is what is unique to the plasma. Here it's interesting to see, of course, when we're using the whole genome sequencing here, 20x coverage is difficult to identify single mutations. So it's more mutational signatures we look at here. Here we identified this platinum signature in the plasma after treatment. So it surely affects the remains of what is present in these patients. What we also found here using this approach was that this patient in the plasma was positive for a FGFR3 alteration or amplification here in the plasma later after the primary tumor, indicating that this may be a target also, a patient that's a candidate for erdafitinib treatment. So in this, the next part of this, going into different clinical trials and how we and others have been using this, and what's the current standard of this. So the perspectives here is that we would like to have trials in this, as I already mentioned here, in this neoadjuvant space here. Can we escalate treatment? I think we need some trials where it's actually driven by ctDNA and molecular markers, and where it's not an add-on on another clinical trial. Then we need trials here in the radical cystectomy space here. Can we do bladder preservation? And trials are ongoing in that space. In the adjuvant setting, we have different trials ongoing. We have the IMvigor011 trial, the modern trial from Dyrskjøt, and then we have the Tombola trial that I'm going to show you some data from Denmark also, where we do serial monitoring of the plasma samples after radical cystectomy to identify if we can escalate or de-escalate treatment. Of course, we need trials in the more metastatic field also. Can we actually use these different mutations we see arising in the plasma for selecting new treatments for the patients? So the IMvigor011 trial, it's a trial, it's a randomized trial to patients that are circulating tumor DNA positive. It's a high-risk patients that go into this and they receive atezolizumab versus placebo. The primary endpoint here is disease-free survival in patients that are ctDNA positive. Compare that to our Tombola trial we're running in Denmark. This is a non-randomized trial. So of course it's not optimal to run a non-randomized trial. We're looking at outcome for these patients, but we have another endpoint in this. So this is all ctDNA patients, positive patients, they receive atezolizumab treatment. And it's all patients that are eligible to cisplatin-based chemotherapy. So it's also low risk and high risk patients that can tolerate this. And the primary endpoint in this trial is complete response, as we defined as a ctDNA negative status combined with a normal imaging status also of the patient. So for all patients that go into the trial or go into immunotherapy are of course ctDNA positive here. So we look at that. I just want to mention this trial also from Dyrskjøt and colleague also, where they started up this trial this year, and it's two different randomized trial, and one where they do ctDNA monitoring here. If they're positive, they randomize the patient to two different settings of immunotherapy, and if they are ctDNA negative, randomized to nivolumab treatment or active surveillance. So that'll be interesting to see when that reads out also. So as I mentioned, the Tombola trial, that's a Danish project where we include patients from 5 different large cystectomy centers in Denmark, and this stands for treatment of metastatic bladder cancer at the time of biochemical relapse following radical cystectomy. Tombola, if you want to know what's behind this strange acronym. So, I already mentioned this. The primary objective here is the complete response, to identify if we can see if the treatment is effective. This is what we're doing here. So we include patients, as I mentioned here, both clinical low risk and high risk patients, is platinum fit, eligible to immunotherapy, and then we collect blood samples at these different time points before, during, and after neoadjuvant chemo, and then at very close intervals after radical cystectomy at 1 month time intervals here in the beginning, and then a little bit less frequent later on. If they are ctDNA positive during this 24 months time point, they start to receive atezolizumab up to 18 cycles of this, and we take blood samples before each installation or each administration of this, and then measure the dynamics of ctDNA during the treatment also. This is a little bit more technical, detailed overview of what we're doing. So in this, we're not using the Signatera or the whole genome sequencing approach. So it's doing whole exome sequencing of primary tumor and germline, and identify clonal mutations from this, and then develop up to 4 different digital PCR assays and use those. So it's really something we can do in a clinical trial, and we can do it because we have this 4-month window here until we need to really start having a readout of the assay. So we have some time to optimize the assays here, but it's not, if we don't have that, then it's really difficult to use digital PCR for this. But we used it here. It was more an economical issue also. Besides this, these blood samples, we're also taking urine samples from the patients, and we're taking rectal swabs during neoadjuvant chemo, and rectal swabs also at the time where they start the immunotherapy also. So we're going to analyze that later. This is the patient characteristics. So this is very small. The only thing I want to show you here is actually you have the patients that are ctDNA positive here, and you have patients that are ctDNA negative here. And here you have if patients are clinical high risk or low risk. So we actually see that patients that are ctDNA positive are both clinical high risk and low risk patients. So that means that according to the guidelines we have now, where we only give patients that are clinical high risk with PD-L1 expression adjuvant immunotherapy, then we're sort of missing out on some patients that may need this treatment. If we take a look at when we detect ctDNA in this cohort, then we actually detect overall it's 56% of the patients that are ctDNA positive. It's not all of them that have developed metastatic disease in the cohort. Yeah, the clinical relapse, you can see the yellow ones here. And in most cases, we detect ctDNA prior to the metastatic relapse, but not in all cases, but most of them. And 75% are actually detected within 4 months after cystectomy. So that also means that we can probably, based on this, identify a window where it's most important to monitor for ctDNA in this setting. These are some swimmer plots from the patients also, and this is just to show you these are all the ctDNA negative patients after cystectomy. So a few of them are positive before. This line here is patients that are clinical high risk, indicated with the red color here. And there are some clinical high risk patients, and this is then the patients that are ctDNA positive, where the pink color here indicates the treatment initiation. And we can see that more of these patients are clinical high risk, but not all of them. And importantly here, I think so we may have the primary endpoint in this trial may be response to immunotherapy, but I think actually this may be the most important readout of this trial as we see it now. So patients that are ctDNA negative here, they have a 98.5% recurrence-free survival at 1 year here. So that actually means that it's should be safe not to give these patients immunotherapy. Of course, this is not a randomized clinical trial, but I think a recurrence-free survival of 98% sort of indicates that it may not be necessary to randomize these patients to plus-minus treatment. So that's actually something that we are working on now in Denmark to use these results to update clinical guidelines and to determine, and we're discussing right now with the hospital settings, if we should actually start now offering this test to patients based on these results here. This is then the primary endpoint, no evidence of disease after immunotherapy. So here we measure at the latest time point where they have received immunotherapy. Of course, it may be they have stopped earlier after 2 cycles, or maybe they get the full series. But it's important here that we actually have 24 patients of these that have completed this that are negative for ctDNA and on CT scans also. So this is a clearance of 55%. So it's not because we believe that this is translating into a clinical response of 55% complete response, because that would be too much. But what we don't know here is actually when we treat these patients with micrometastatic disease, patients that are clinical low risk and have not really been, as far as I know, included in the different randomized clinical trials where atezolizumab was investigated, it may actually be that this treatment may be more effective for these patients that have minimal residual disease. But we don't know that. These are the data, and we'll have to see the clinical outcome of these patients in some years. So hopefully this may end up with being the future standard for patients, where I think these are probably the strongest data we have right now. So there may be these studies ongoing where can we escalate, de-escalate during neoadjuvant, can we do bladder preservation? But I think here in the adjuvant setting, doing de-escalation and escalation of treatment, I think this is where we have the highest opportunity right now to actually do this, and the data we have start to indicate that this may be possible. There are some assay considerations I want to mention also. Of course, now here we've used the digital PCR. Digital PCR is extremely sensitive, but it just takes a lot of time to develop these assays and test if they are sensitive and specific. So here we collaborate with the C2I and Veracyte also on this cohort, and we have analyzed the first plus blood samples from the first 100 patients in the trial using their technology also. And then we compare the digital PCR assays to the whole genome sequencing assay. And we can use that as a sort of a bridging study to see if it's safe to shift into that other platform. This is the result from that comparison. So this is actually 1,282 whole genome sequencings measurements of plasma samples when we compare to the digital PCR assays we have. This is the tumor fraction, whole genome sequencing, tumor fraction of digital PCR. So overall, there's a very good correlation between this. There are some differences also, and some here where we see that it's only positive in digital PCR, and some where it's only positive in whole genome sequencing, here in the lower part of this. And what that means yet, we really don't know, but there is this almost 13% that are positive using digital PCR that are not positive using whole genome sequencing of these samples, while it's only 4.2% the other way around. This is just to show some correlation of this, where you can see the digital PCR assays here. For this patient, there's 3 different assays here, and then you have the whole genome sequencing approach here using I think it's blue line. But overall, there are some nice correlations between the techniques. But I think this figure here is probably the most important to evaluate if we can use this technology. So you can see here that the whole genome sequencing approach, if we look at clinical outcome for the patients, we have a sensitivity of 80%. We have the same sensitivity using digital PCR also. So this is clinical sensitivity, so it's not assay sensitivity. But the specificity is higher for the whole genome sequencing. We call this positive simply than we do with the digital PCR. So these numbers may may be nice and may indicate that the whole genome sequencing approach may be better. On the other hand, we see here some events here where they have metastatic disease where we don't detect it using whole genome sequencing. So the question is if it's sensitive enough, or where should we put this limit? Is it better to have maybe a less specific assay, but then ensure that we actually capture all the recurrence events, or would it be acceptable to run this where we may detect, we may miss some of them? So it's a discussion we need to have with these assays, and this is I think what we're going to see when we're starting to compare all these different assays. To sort of use these results in other cancers, we have a research center in Denmark, so a virtual center all over Denmark, where I'm heading this together with my colleague Lars Andersen. We are trying to have different, using the experience we have from bladder cancer and his expert in colorectal cancer, running different trials on that. We're trying to use that experience to make it easier to incorporate ctDNA for decision making in other clinical settings also. So we have these different focus areas, as you can see here. I think most importantly here, we have different national infrastructures where we try to discuss and build the best practice for liquid biopsy collection. How do we process the samples across Denmark, and then develop some different SOPs so everybody is doing this optimally, where they may not have the same experience in this methods for ctDNA detection. What is needed? You may need some very sensitive assays in an adjuvant setting, but may not need the same in the metastatic setting, for instance. Bioinformatic procedures, algorithms for how to call ctDNA, we're working on that. We're trying to develop the whole genome sequencing assays also, where we are sort of more independent of the companies. We have a health economist associated with this also, so we can sort of make some evaluation to see if this is a benefit, and of course dissemination and education. We started this in 2020, and we have several different clinical trials ongoing in this, and this is of course independent PIs and clinicians and research groups that are running this, but it's being run in this in the framework of this center also. So we have more than 40 clinical protocols now running on ctDNA. It's not all intervention studies. More than 3,000 patients have been included, and we have more than these 50 departments included in this also. So it helps us sort of build some more evidence for ctDNA-guided treatment in Denmark, and it also helps us to attract more funding for this. So that I think I hope I've convinced you, if you were not already convinced, that the ctDNA in muscle-invasive bladder cancer is a very strong biomarker, especially for risk assessment after cystectomy. We can also use it for monitoring response during chemo and immunotherapy. But we really need to demonstrate this in the framework of these different clinical trials before we can start using it. I know it is being used in different settings now where clinicians order the test, but the question is just, do we know enough about this to actually make a treatment decision based on it? We really need to demonstrate if we can improve overall survival, improve the quality of life, and reduce costs. We need to know more about the urinary tumor DNA. I think that's more we are still at an early stage here, and we need to learn more about the different techniques that are available now. They're evolving, they're becoming more and more sensitive and specific, but how sensitive tests do we also need? Because if the tumor is growing exponentially, then it may also be a matter of just measuring 1 week later, and then you can actually measure the ctDNA instead of having this 1 part per million sensitivity of a test. So that's something we need to consider also. But with that, I want to thank you for your attention, and thanks to my team here and the collaborators on the Tombola trial and all the different funding agencies and companies that has been involved in this. So thank you very much for your attention. I hope you have some questions.